Hello, everyone, and welcome to Pre-Hospital and Disaster Medicine podcast number 10. My name's Joe Cuthbertson. Talking with me tonight is Greg Ciottone, the President of the World Association of Disaster and Emergency Medicine, and Attila Hertelendy, the Associate Director of Research, Beth Israel Deaconess Medical Centre Fellowship in Disaster Medicine. And they're talking tonight about a recently published paper in Pre-Hospital and Disaster Medicine, State Preparedness for Crisis Standards of Care in the United States, Implications for Emergency Medicine, Management, I should say. Welcome, Greg, and welcome, Attila.
Thanks, Joe.
Thank you.
Thanks for having us.
Great to have you here talking about this article. Reading through it, I was quite interested, looking at the contrast between the USA and Australia, and I'm sure many of our listeners around the world would be considering this paper, particularly with COVID-19 and how it's affected health systems around the world. Maybe to start with, Greg, could you describe what crisis standards of care broadly means?
Sure. So as in the name, crisis standards of care, it's meant to help to define some of the practices that healthcare providers might do in the event of a disaster or a crisis, with the overarching idea of trying to provide the most good for the most people in a situation when your resources may be strained. So in disaster medicine, we always talk about some degree of surge, whether it's a short-term surge or long-term surge like a pandemic or what it might be. So it's the idea of when that patient surge comes, whether it's in the emergency departments, it's the intensive care unit, it's the floors. How do you manage your limited and sometimes not sufficient resources to handle that surge? So it's the idea of taking the typical standard of care that you might practice down to a certain degree, so that you can provide that better care, for more people. Probably what got the most attention in the idea or the area of crisis standards of care in this COVID-19 pandemic, is the idea of rationing ventilators, sharing ventilators, that sort of thing. When in reality, actually, it was much more utilized in other areas. So, for instance, every time you were to open up an alternate care site, for instance, an ACS, and you're providing hospital level care in a field hospital somewhere, let's say in a convention center or something like that, that is a slight lowering of the standard of care so that you can provide, more care for more people. So handle that surge. And that's an example of crisis standards of care that was actually implemented a lot more than some of these others, like rationing ventilators, et cetera.
Right, Greg. And one of the things that we've also seen was that crisis standards of care is not necessarily a new concept. This has been around for quite some time, for over a decade. The Institutes of Medicine had published guidance in this regard back in 2008, 2009. But the key takeaway then, of course, is that in that crisis standards of care, the key differentiation in terms of terminology is that patients are going to get the best care that's available rather than the best care possible. So those are the key kind of terminology differences when we enter into crisis standards of care.
It's an interesting point, Attila, and it sort of feeds off some of the thinking that I had when Greg mentioned ventilator access. So given that crisis standards of care have been around for a while, what do you view are the ethical challenges with it, and why is there hesitation around implementation of it?
Well, there's a lot of challenges in terms of the ethics. A great number of dimensions have actually unfolded. Some of the major issues is, of course, equity, the challenges related to personal physicians feeling where they enter into a situation of moral distress or trying to alleviate that situation of moral distress. And then we've seen in the United States the whole concepts related to vulnerable populations in terms of who gets access. We know that vulnerable populations are oftentimes during disasters getting the short end of the stick, as it were. Resources get to them last. Sometimes in planning, they're often forgotten. in certain cases, especially older adults and those with disabilities and those in low-income communities. So those are some of the big ones that have really created a lot of concerns in terms of writing policies and protocols in terms of how do you address some of those groups of people. And then there was recently some social justice related issues related to that in terms of some of the communities that have often been forgotten or overcome in terms of racial barriers. For example, we know that has become a hot topic. African American, Latino, Native American communities were very heavily impacted during COVID. And of course, we know that in these communities, they're very vulnerable to risk factors for COVID, such as heart disease and then the social constructs there in terms of vulnerabilities due to crowded living conditions. So social justice and equity and the ethical conundrum here has been really an emotional topic, frequently discussed in the media and academia. And so this has caused a lot of challenges for policy leaders to make those ethical based decisions and not allowing emotions and politics or personal feelings to really dictate those actions. Greg?
Yeah, I think that would also should actually kind of lead into a conversation too about the psychosocial implications of the application of crisis standards of care. And I think we saw a lot of this during the first peak, and we're starting to see it now with the second peak. But it does take an emotional and sort of a psychosocial toll on caregivers who are typically accustomed to providing, again, as Attila said, the best care possible, and available. Now having to lower that standard of care to a certain degree can take a psychological toll on the providers as well. And, we know there's been issues with healthcare workforce, longevity through this crisis and just the impact of the healthcare workforce. So I think that probably should be noted as well as part of this kind of challenge around the implementation of crisis standards of care.
So interesting feedback, and sort of one of the things that sort of jumped out at me with that discussion was that this is a population health response or a public health response. You're taking a standard of care to a group of people. And I note that it's the focus of this article was around state preparedness for crisis standards of care. What role, or should the federal government have a role in declaring crisis standards of care? And what are the pros and cons of them either having a role or not having a role?
Yeah, I think, and again, we're looking at the U.S. model here, and models obviously differ around the world, but that overarching kind of idea of a federal level of government and a regional or state level of government and the interaction between the two. Looking at the U.S. model and what's happened here, I do think that there should be essentially a role for the federal government in the triggering, let's say, of crisis standards of care through some sort of guidelines or something else. Now, you probably know in the U.S. we have this rather complicated series of emergency and disaster declarations that we can do, and most of these were actually activated back in March. But there's the Emergency Act through the Stafford Act is activated. There's the Public Health Emergency Act. There's also something, but my point being, I guess, there's nothing really specifically saying that we are now going to enter into a state or a condition where we can implement crisis standards of care. And here are some kind of basic guidelines for doing that. That's on the federal level. Then allowing states to then further modify that, because as we all saw in the United States and elsewhere, we acted like essentially 50 different countries as opposed to one country and 50 different states. So, and part of that was just the way that the pandemic behaved. At one point, New York was on fire and other places weren't. Another point, California was on fire and other places weren't. So, crisis level standards of care, may or may not be required in certain places. But, if we were to do something as an overarching kind of federal declaration that we are now in a condition where crisis standards of care can be implemented, and here are some basic guidelines on how to do that, I think that would enable states to a much greater degree. The closest I think we come to that is a public health act called the Public Readiness and Emergency Preparedness Act, which is different from the Public Health Emergency Act, but can be done by the Department of Health, Secretary of the Department of Health and Human Services. And what this does, for the most part, is remove some liabilities over implementation of different countermeasures towards whatever emergency or disaster you're dealing with. It's not exactly a triggering or crisis standards of care, but it somewhat approximates that by removing some of these liabilities. One of the problems is, I think, that there's really no muscle memory for how we should act as a federal or a state government in a pandemic. Most of these emergency acts that we have in place and are activated historically have been for natural disasters, and because of that, they've been in isolated places. So these one or two states might be under a declared federal emergency and state emergency, whereas the rest of the country's not. With a pandemic, the entire country the entire world essentially is, and I don't think we have the muscle memory and how best to do that. And I think that coming on the other end, the other side of this pandemic, we are going to see some modifications probably on both the federal and the state level of how we do these.
That's an interesting point, Greg. And without going down too much of a rabbit hole, do you feel that crisis standards of care would be equally applicable for natural hazards as they would be pandemics?
I do, but obviously to different degrees. Again, disaster response crises like this, it's all a matter of surge. So when we talk about, for instance, disaster triage, let's say for a mass casualty incident, that's essentially what we're doing, right? We're actually implementing short-term crisis standards of care. So we're going to provide, again, to provide the most good for the most people, we're going to have this designation here in the U.S. We use the, red, yellow, green, black, and we're going to ration our limited resources, our limited care abilities because of the surge until we can justify that equation and our resources, our assets essentially equal our needs, and we can go back to our normal practice. So that's in a way that's implementing it. So I think in any disaster, in any crisis where there is surge, again, short-term and long-term, implementation of some degree of crisis standards of care, and of course they will differ in each event, each disaster, but that is part of your response.
I see. So in the setting of state-defined crisis standards of care, what do you feel that they'll allow or provide scope for hospitals to do?
So a couple of points regarding the triggering of crisis standards of care. These were some of the issues that had been prevalent during COVID-19 response, is the hesitance really to declare crisis standards of care and what those triggers are. And if we look at some of the state plans, one of the issues was that it was not clearly defined. And from a global perspective, the WHO never really defined what would trigger a crisis standards of care either, which we highlighted in one of our early papers back in March, talking about the ethical challenges of implementation of crisis standards of care, is that reluctance because it was not clearly defined. So, of course, having some type of a federal declaration, at least giving that permission, if you will, or giving the green light to states to be able to implement them early enough is key. Because what we saw was it wasn't until December of 2020 where the National Academy of Medicine came out and urged the country basically to implement crisis standards of care and to work with governors, the state health departments, and really all the stakeholders to implement standards of care. And there's been a great deal of hesitation to do this, particularly in California, where the challenges were the perceptions that were formed by competing hospitals. As you know, many of the hospitals in the United States are for-profit entities. And the challenge was that hospitals felt like they didn't want to be seen as a failure if they implemented crisis standards of care. And so they were really reluctant to declare that because really the state in California just wouldn't do it. It would not declare crisis standards of care because of the politics around this. So if you kind of take away some of those barriers of implementation where because this is unprecedented. We've never really done this before, and we don't really want to get into that situation where we are in crisis standards of care. But the reality is that we were in crisis, and particularly in California, where we didn't have ICU beds, for example. So you're in crisis standards of care, but you haven't actually declared it. So there's that conundrum in terms of that triggering event. And I think that's a major problem, and it continues to be a problem in California, where that reluctance, that perception of failure, and so if it was just done from the state level, it would take away and absolve all the hospitals from that feeling that somehow they failed or did something wrong or that type of thing, and it really helps the community and the hospitals get back on their feet and to be able to share resources and do what they need to do, just like they found in New York City hospitals during the pandemic. They found that clear, formal declarations really helped to reduce burdens on care providers, and it turned out much better, and also reduce that emotional toll that comes with making these life and death decisions when it comes to rationing care.
Yeah, I mean, I completely agree, and I think it's essentially what it does is it takes the pressure off of hospitals, right? So this entire kind of environment, when you get into a surge situation, especially when it's longer term, like a pandemic, you don't really see the light at the end of the tunnel. It's all kind of uncharted waters. We haven't been here before. It just, all of those question marks, all of that anxiety that individual hospitals, in fact, individual practitioners, have about the care that they're providing, is lifted to a certain degree if the state is saying, again, as an overarching statement, this state now, we are in a time of crisis standards of care implementation. And that just allows hospitals to understand that they're not an island out there. They're not doing this themselves. We're all in the same boat, and we're kind of working together.
It's a good point. And Attila, you touched on some of the experiences in California and the US, like Australia, like the rest of the world, has all been working through the COVID-19 pandemic. Overall, what has the US experience been like with crisis standards of care for COVID-19? And what do you feel are the key lessons that we can take from it so far?
Well, in our paper, we didn't really mince too many words. To be politically correct, the results have been mixed. The application of crisis standards of care have been mixed. We went so far as to say that the U.S. had some failures with regards to implementation of crisis standards of care across the nation from a federal level, and some states have done better than others. For example, Arizona and New Mexico declared, for example, state level declarations of crisis standards of care, and those really helped protect their physicians from liability. It really helped them deal with moral distress and some of those conundrums. And what we've also seen is that there are some states that were really prepared and that had actually protocols in place. They had very good preparedness done. Minnesota, for example, others have led in this area in terms of good preparation, good plans. However, they never implemented them. And so that was sort of the tipping point, is that we knew that some facilities across the country were already in crisis. And yet that triggering event was not clearly delineated in their protocols or even in their standards of care, because they're issuing it as guidance. And we found that actually in much of the COVID-19 response nationally, it doesn't matter what you look at, vaccine rollout or whatever, it's the guidances can be very generic, and sometimes they're not very specific. And a lot of the states were looking for that very specific, what triggers crisis standards of care and who can actually do it. So that, I think, is a really important lessons learned, is that this needs to be much more descriptive. in the vernacular conversations that we're having, crisis standards of care should exist, and that, yes, we are in crisis standards of care, and this is what this means, and be able to work through that. Because if there's that hesitancy on what this actually means when you are in crisis or you declare that, I think we need to get beyond that, because there's still some stigma attached to that that's preventing some states from really doing that. Much of it goes back to politics and image perception that somehow a state failed. But I don't think that in the pandemic, that's a very rational lens to look at things. But yet that's what's happened in the States. So I think we learned quite a bit. There have been pockets that have done well within the States, but others have fallen short of the mark.
Yeah, and I completely agree. And also, I don't think there's any blame to be laid anywhere. This is a process we've been all going through. Everybody, every state, every facility, hospital has been doing their best to try to go through this, again, with no muscle memory, no good history of how best to do it, uncharted waters. So these are all the kind of lessons to be learned. So when we do the big, after action meetings and hot washes, et cetera, over this and how we can do things better, we'll be looking a lot at this. I mean, don't forget also, in some cases, we went a little bit overboard on how we did this. So, there was a number of alternate care sites out there, including, the Navy ships that came in that were underutilized, right? So we set up these big facilities and very few, if any, patients were cared for there. None of these, no mistakes were made. These are just lessons to be learned. And I think, when you're dealing with something that's both as nebulous as how to implement this idea of crisis standards of care, so essentially, making the standard of care match the need with the surge, in a situation also, so as nebulous as that is, in a situation also that's as fluid, changing day by day, and as critical, right? I mean, we're really talking about people's lives at stake here. This makes for a very, very difficult conundrum to get through, to deal with. And I think all the lessons that we can learn from this will help us in the future. But again, the future, if we go through this again, we're still going to have variables presented to us that were unexpected, that we're not expecting to do. So one thing I always like to say is better the planning than the plan. I think when we get over this, on the other side of this pandemic, we need to all sit down and really study how we did everything, in this response, but in particular, how we implemented crisis standards of care and how we can maybe do a better job with that, with the understanding that, we can never give an absolute roadmap that will get us from A to Z with no hiccups. There are going to be hiccups in disaster medicine. That's the nature of the beast. But the more that we can kind of implement there and put into place maybe guidelines, federal, state, integrate more with hospitals based on our experience in this pandemic, I think the better that we'll do in the future.
Yeah, and I think also we need to be cognizant that in the United States, particularly, we have not really seen the worst of the COVID-19 surges yet. Even with the presence now of more contagious strains of the virus, it suggests that we need to be diligent and still consider that we might have to implement at some point in time, hopefully not, crisis standards of care. But the other thing that comes to mind is the importance regarding listening to clinical advice from the medical community on the part of the healthcare administrators. So the collaboration that needs to continue to occur more closely is that relationship between healthcare systems leadership, hospital leadership, and the clinical community. The voice of physicians needs to be heard when it comes to surge capacity planning, what's happening on the front lines. That has occurred. We're learning more about that, but that still needs to be given priority, is to listen to what's happening on the front lines, to be able to adapt from the leadership perspective, from the hospital leadership, because at times there was some siloing, particularly in incident command systems that weren't functioning optimally. Decisions were made by administration that were perhaps not congruent with what the clinical leadership wanted to do. And I think we need some opportunities to reflect on, or we should take some time to reflect on how to best integrate those decisions so that that crisis standards of care can be implemented swiftly without barriers, and be able to manage those resources effectively. Because the public is, watching, and they're owed that level of communication to know what's going on. They see it in the news, they see it on Twitter, they see what's going on, but they don't get that communication necessarily from the hospital systems or even the state in some certain circumstances. So I think we have some opportunity to improve there.
Some really valuable insights there. Greg, Attila, thanks so much for your time today talking about your recent article, State Preparedness for Crisis Standards of Care in the United States, Implications for Emergency Management. Recommend to all our listeners out there to access the latest issue of PDM, read that article, and take a chance to read the other public publications in there. Thanks very much again for your time.